Gastrointestinal Disorders by Mark Britton. Here we have Miss Mary Jenkins. She's a 55-year-old woman with diabetes and opiate dependency for chronic back pain. She has come into the office complaining of abdominal tenderness and abdominal pain with occasional nausea and vomiting. Hepatitis, pancreatitis, irritable bowel syndrome, diverticulosis, peptic ulcer disease, hiatal hernia. Okay, Mary. Hepatitis, pancreatitis, irritable bowel syndrome, diverticulosis, peptic ulcer disease, and hiatal hernia are the gastrointestinal disorders I'm going to go over with you. General characteristics of hepatitis. Hepatitis is an inflammatory condition of the liver that can be caused by viruses, drugs, and toxins. Chronic autoimmune hepatitis is a disease in young girls and menopausal women. There are 5 hepatitis viruses: hepatitis A, B, C, D, and E, with hepatitis A, B, and C occurring commonly in the United States. There are 4 phases of the acute viral hepatitis. You have incubation. During this phase, enzymes hepatic aminotransferase, aspartate aminotransferase, and alanine aminotransferase begin to rise. You have pre-icteric phase. This is the onset of symptoms phase. Icteric phase. During this phase, the symptoms abate. And convalescent phase. This is where you have a relapse in symptoms or jaundice. Management and lifestyle changes of hepatitis. The management of acute viral hepatitis is supportive. Bed rest at home is recommended during the period of acute symptoms. Antiemetics and intravenous fluids are administered as needed. Hepatitis A virus often occurs in epidemics where water becomes contaminated with sewage. Outbreaks can be traced to eating uncooked shellfish, particularly oysters from contaminated waters. During reported outbreaks, people should heed advice not to eat raw shellfish or other contaminated foodstuffs. General characteristics of pancreatitis. Pancreatitis is an inflammatory condition of the pancreas that may be an acute or chronic process. Recovery from acute pancreatitis is often complete with restoration of normal pancreatic function. However, chronic pancreatitis can lead to permanent pancreatic dysfunction, which results in the malabsorption of foodstuffs. The pancreas has both exocrine and endocrine functions. The exocrine function is to secrete into the intestine fluid that contains enzymes that aid in the digestion of fats, carbohydrates, and proteins. Signs, symptoms, and diagnosis of pancreatitis. Abdominal pain that radiates to the back is the most common symptom of acute pancreatitis. Nausea and vomiting also occur. On physical examination, hypoactive bowel sounds and abdominal tenderness are usually present. Patients may be febrile, tachycardic, and hypotensive. When the classic triad of pancreatic calcification is seen on an abdominal radiograph or ultrasound, fatty stools and diabetes mellitus are present. The diagnosis of chronic pancreatitis is obvious. However, this triad occurs only 1/3 of patients. A low serum level of trypsinogen can establish the diagnosis. Management and lifestyle changes of pancreatitis. Putting the pancreas to rest is the aim of the medical management of acute pancreatitis. This is accomplished by not feeding the patient. Intravenous fluids are necessary to maintain hydration and electrolyte balance. Analgesia is necessary for patient comfort. Nasogastric suction and antibiotics do not appear to add benefit in the management of acute, uncomplicated pancreatitis. Acute pancreatitis usually resolves within 1 week. Patients should avoid the precipitating causes of acute recurrent pancreatitis, such as alcohol or drugs. For those with chronic pancreatitis, alcohol and fatty meals should be avoided since these commonly exacerbate the pain and malabsorption that occur. General characteristics of irritable bowel syndrome. Irritable bowel syndrome is characterized by cramping, abdominal pain, and alternating constipation and diarrhea. IBS affects all age groups but is most common in young women. In many patients with IBS, substantial abnormalities in colonic motility have been detected. Therefore, the disease should not automatically be attributed to an underlying anxiety disorder or depression. Signs, symptoms, and diagnosis of irritable bowel syndrome. The symptoms of IBS are intermittent and variable. They may be precipitated by a fatty meal or emotional stress. Crampy abdominal pain with either constipation or frequent low-volume stools are seen. The differential diagnosis of IBS includes carcinoma of the colon, diverticulitis, lactose intolerance, and inflammatory bowel disease. If symptoms persist, a gastrointestinal workup must be done to exclude these possibilities. These usually consist of an upper GI series with small bowel follow-through or upper endoscopy along with a barium enema or colonoscopy. Management and lifestyle changes of irritable bowel syndrome. Reassurance and alteration of diet are the mainstays of therapy. Reducing fat in the diet and increasing dietary fiber is often helpful. Anticholinergic medications such as dicyclomine hydrochloride, which reduced gut motility, may be used. Reducing fat intake and increasing fiber intake may lead to improvement in symptoms. Emotional stress that precipitates symptoms should be avoided if possible. General characteristics of diverticulosis. Diverticulitis describes the condition in which a diverticulum becomes infected as a result of obstruction from the thickened stool. A diverticulum is a mucosal pouch that extends through a weak spot in the colon wall into the abdominal cavity. Signs, symptoms, and diagnosis of diverticulosis. Diverticulosis is usually asymptomatic, but it can result in chronic, recurrent abdominal pain and rarely gross rectal bleeding. Increased abdominal pain, diarrhea, and fever are associated with diverticulitis. Rectal bleeding is distinctly unusual. Management and lifestyle changes of diverticulosis. An increase in dietary fiber may reduce the symptoms associated with diverticulosis. Diverticulitis must be treated with antibiotics and some form of bowel rest. Changing from a low fiber to a high fiber diet may be beneficial. One should also avoid eating foods that contain small seeds such as tomatoes, strawberries, popcorn, nuts, and other foods that break into small, undigestible particles. General characteristics of peptic ulcer disease. Peptic ulcer disease may involve the esophagus, stomach, and duodenum. Regardless of the location, there is mucosal injury that leads to formation of an ulcer. Signs, symptoms, and diagnosis of peptic ulcer disease. On physical examination, abdominal tenderness may be present. The stool test heme positive and gastrointestinal bleeding is present. When bleeding is significant, pallor and hypotension are present. Management and lifestyle changes of peptic ulcer disease. Antacids, which neutralize the stomach acid, and H2 blockers, which prevent the secretion of gastric acid, promote healing of peptic ulcer disease. Behavioral changes can significantly impact the rate of healing and recurrence of peptic ulcer disease. Smoking cessation, abstinence from alcohol, and avoiding aspirin are all beneficial. General characteristics of hiatal hernia. The esophagus passes through an anatomic defect or hiatus in the muscular diaphragm as it joins the stomach. A hiatal hernia describes a condition in which the hiatus is enlarged, allowing a portion of the stomach to pass upward into the thoracic cavity. Symptoms and diagnosis of hiatal hernia. The patient with peptic or reflux esophagitis complain of symptoms like peptic ulcer disease or heartburn. The diagnosis may be apparent from the history when postprandial and supine symptoms occur. Management and lifestyle changes of hiatal hernia. When a hiatal hernia is associated with symptoms of reflux esophagitis, therapy is indicated. When nighttime symptoms are prominent because of assuming the supine position, evening fasting, and elevating the head of the bed with 15 centimeter blocks may provide additional benefit. Avoiding agents that cause relaxation of the lower esophageal sphincter, elevating the head of the bed on 15 centimeter blocks, and nighttime fasting can alleviate esophageal reflux. Okay, Mary. So after looking at your chart, looks like IBS and your diabetes kind of coincide with each other. What happens is the diabetes damages the nerves around the gut, which can lead to IBS, and that goes hand in hand with your opiate dependency. You can have a functional GI diag such as IBS with constipation. The opiate will further exacerbate the constipation and cause more stomach pain or abdominal pain. As far as your hiatal hernia, with your constipation and the opiate causing constipation, it's not a classic risk factor, but straining can cause a hiatal hernia. Now, you do not have pancreatitis because your trypsinogen levels were normal, but that's also another factor, risk factor. It could be chronic pancreatitis. 6% to 12% of patients progress to chronic pancreatitis after the initial episode of an acute pancreatitis from opiate abuse. And that's it, Mary. Thank you.